Hey everyone, and welcome to this explainer. Today, we're decoding something absolutely fascinating, the intersection of raw, messy human reality and rigorous, hard data. We're going to dive into a brilliant curriculum designed to teach evidence-based medicine, or EBM, but taught entirely from first principles. So we're not just looking at dry medical research, we're actually going to understand this through the lens of a clinician's true cognitive workflow. And to do this, we'll be leaning into the Vibrown's AI-driven Socratic learning approach. Basically, that means we're going to guide discovery and ask some big questions rather than just spoon-feeding you the answers. It's honestly an incredible way to map out the entire clinical cognition operating system.
Okay, let's jump right into this. The core philosophy that drives this whole approach is surprisingly simple, starting with the patient, not a p-value. When we talk about evidence-based medicine, it is just so easy to get lost in the weeds of statistical significance, data points, and dense research papers. But true clinical thinking, it's grounded in reality. It is entirely anchored to the complex, breathing human being sitting right there in the examination room. You can't just apply abstract statistics to a void. You literally have to apply them to a person.
To really grasp this, it helps to compare how different minds actually tackle a problem. On one side, we have the techie view. If you come from an engineering or data background, your default is usually algorithms, statistical models, and aggregate data, right? You want to see the macro trends. But on the flip side, we have the clinician view. A medical professional has to approach a highly complex, completely singular, and often unstructured system, the individual patient. They have to prioritize the patient's unique history in their physical examination above all else. The beauty of this explainer is how we're going to bridge these two seemingly totally different worlds.
So here is our quick roadmap for today. First, patient over p-value. Second, the clinical workflow. Third, validating the evidence. And finally, EBM for techies. All right, kicking things off with Section 1, patient over p-value.
The patient-centered approach is absolutely the foundational step of this entire clinical operating system. Before any math happens, before a single research paper is open, clinicians have to act as pure data gatherers. They're taking in the unstructured, chaotic reality of a human life directly through the patient's history and physical examination. Think about it. You can't just search a database for a diagnosis if you haven't first properly mapped out the physical and historical reality of the person actually sitting in front of you.
Now, channeling that Vibrown Socratic method for a second, I want you to really think about this. Once we have the patient's history, all this messy, unstructured human data, how do we actually organize it? You've got a random collection of symptoms, timelines, and physical observations. What is the very next logical step in processing this raw information so it actually becomes useful?
Which brings us to Section 2, the clinical workflow.
So step 1, as we just discussed, is gathering all that raw clinical data through the history and examination. But step 2 is where the structuring happens. Clinicians use what are called SOAP notes, which stands for subjective, objective, assessment, and plan, to format that information. This turns a rambling narrative into a structured, highly trackable medical record. Then step 3 is driving clinical action and cognition utilizing the PageR framework, which ensures we predict and justify our clinical reasoning. By following these exact steps, a clinician translates a real-world, unpredictable person into a highly structured clinical problem that can actually be solved.
Okay, so we have our structured problem. But here's another Socratic question for you to chew on. How do we actually protect the patient from bad data? Because once you have a structured clinical question, naturally, you're going to go looking for answers in the medical literature. And the harsh reality is, not all evidence is created equal. If you take flawed data and apply it to a real patient, the outcomes can be literally disastrous.
And that leads us straight into Section 3, validating the evidence.
Now, what's really interesting here is that we usually hear the phrase spotting fake news and we instantly think of social media or politics, right? But critical appraisal in medicine is quite literally the practice of spotting medical fake news. It's your vital first line of defense. This isn't just some academic exercise you do to pass a med school test. It is a highly practical shield against misinformation that protects the integrity of the entire clinical decision-making process.
So the crucial point here is knowing exactly how to rank that evidence. And for that, we use the evidence pyramid, which basically acts as a hierarchy of truth. At the foundational level, you have case reports, which are just observations about individual patients. But as you move up the pyramid, the data validity gets stronger and stronger, moving through complex randomized controlled trials, or RCTs. Finally, right at the pinnacle, you have pooled meta-analyses. These combine multiple trials to give you the absolute highest quality of evidence. Understanding exactly where a study sits on this pyramid helps you weigh the quality of the data you're about to apply to your patient.
Moving on to our final agenda item, Section 4, EBM for Techies.
I absolutely love this part. This is essentially a Rosetta Stone for evidence-based medicine. Over on the clinical side, you have PICO questions: patient, intervention, comparison, and outcome, which is how doctors formulate their clinical inquiries. For a techie, that is literally just a search schema. What about randomized controlled trials? Well, those use the exact same logic as A/B tests in software and marketing. Likelihood ratios? Those are simply Bayesian updates, adjusting probabilities based on new incoming evidence. And clinical practice guidelines built on the grade system? That is the medical equivalent of weighing test coverage versus a ship decision in software deployment. It brilliantly illustrates that clinical research uses the exact same logic as engineering frameworks.
But here's the catch. Even with perfect logic and perfect translations, you have to be prepared for the unexpected. What actually happens when the underlying data completely surprises you? Because when you apply this highly structured, evidence-based approach, you very often uncover some incredibly counterintuitive insights that completely defy basic common sense.
Take a look at this number, 8%. One of the most fascinating insights revealed in this curriculum is how diagnostic tests fluctuate wildly based purely on context. You can take the exact same medical test, right? And in one population, it will give you a highly reassuring 90% predictive value. But you take that exact same test and apply it to a different population, and its predictive value plummets to just 8%. It shows exactly why context, and specifically disease prevalence, completely changes how useful a test is for your specific patient.
And here is another massive shocker from the course, the number 25. You might read a flashy headline or a pharmaceutical claim touting a massive 40% risk reduction for a new drug. Sounds amazing, right? But when you actually crunch the numbers and calculate what's called the number needed to treat, or NNT, that 40% reduction might actually mean you have to treat 25 different people with this drug just to help a single one of them. It completely changes the risk-benefit conversation you're having with the patient sitting in front of you.
This right here is why learning evidence-based medicine from first principle is just so incredibly powerful. It forces you to look past the marketing, way past the raw p-values, and get back to the human reality. So ask yourself, are you ready to turn a vague clinical worry into an answerable, evidence-backed question? Because once you master these foundational steps, mapping the patient, structuring the data, and translating the evidence, you are totally ready to advance the PICO framework in the next stage of learning. Keep asking those big questions, keep validating your data, and always, always start with the patient.